Hello guys, today we are gonna discuss about acute pancreatitis. I hope you are having a very nice time. If you are new to this channel, please do subscribe. Pancreatitis means inflammation of the pancreas, and acute means presenting as an emergency condition with abdominal pain. The acini of the pancreas secrete pancreatic enzymes into the duodenum, which helps primarily in digestion of fat. The enzymes at the duct are inactive, while in the duodenum it becomes active through kinase. Thus, in acute pancreatitis, there is premature activation of enzymes, which will result into autodigestion of the gland. The enzymes that undergo this premature activation are amylase, protease, and lipase. The amylase is increased threefold above the normal level in the blood. The protease damages the cell and vasculature, and lipase undergoes fat necrosis. Acute pancreatitis is caused due to injury to pancreas, injury to ductal epithelium, and due to impairment in secretion of zymogen granules, which will result into delay in enzyme secretion. Thus, it will trigger acute pancreatitis. Talking about etiology, the most common etiology is gallstones. Here we have a mnemonics: get smashed. G stands for gallstones. The gallstones at the lower part of the common bile duct can obstruct the pancreatic duct. Thus, it can also be the stone in the ampulla of water, which will cause regurgitation of bile, thus resulting into activation of enzymes. So the stones in the lower part of the common bile duct can cause obstruction of pancreatic duct, and there may be stone in the ampulla of water. And even if the stone in the ampulla of water, the mere passage of stone in the ampulla of water can cause or can initiate an attack of acute pancreatitis. The second cause is ethanol or alcohol. And the third most common cause is trauma. From S we have steroids. M we have mumps, that is infectious disease. From A we have autoimmune conditions. S scorpion. S hypercalcemia, hyperlipidemia. E ERCP, and D drugs. So acute pancreatitis, it causes major burn of the peritoneum, resulting into protein-rich exudate. Pancreatitis is all about P. Lipase will cause destruction of fat into glycerol and fatty acids. Fatty acids will combine into calcium. If in severe condition, it can cause hypocalcemia by forming insoluble calcium soaps. So in the severe condition, excess calcium is consumed and it can cause hypocalcemia. In acute pancreatitis, it's all about P. It's premature activation of enzymes and pancreatic inflammation. So gross appearance. The severity of inflammation ranges from mild edema to hemorrhagic pancreatitis. Hemorrhage will result into hemorrhagic ascites. You can see here the hemorrhagic pancreatitis, all the hemorrhage in the pancreas, clotted blood. It can also appear as necrotizing pancreatitis. You can see here the black or brown portion, which is necrosis. And the gross appearance also contains the white spots of fat in the peritoneum. This is a transverse section in the abdomen. This is pancreas in the retroperitoneal position. And this is stomach, which is an intraperitoneal organ. So this is the lesser sac. So the first, what happens in acute pancreatitis is there is pancreatic inflammation due to autodigestion, premature activation of enzymes, and it will cause peritoneal inflammation. It's all about P, premature activation of enzymes, pancreatic inflammation, and peritoneal inflammation. It's all about P. This peritoneal inflammation will present as upper abdominal pain, which will radiate to the back. The onset is acute, the course is gradual, followed by heavy meals or ingestion of alcohol. Vomiting is always present when there is upper abdominal pain due to pyloric spasm. So we have two symptoms, upper abdominal pain and vomiting. Vomiting is always present in case of upper abdominal pain due to pyloric spasm. Signs: general and local signs. We have two types of signs here, general and local. General all over the body, and local is specific to the region, abdominal region. So there is mild tenderness and rigidity. Why mild? Because pancreas is a retroperitoneal organ. It is away from the sensitive parietal peritoneum. So the blood trickles through this extraperitoneal space to the loin, giving grey Turner signs. There will be bruising in the loins. There will be bruising around the umbilicus due to the blood. This is known as Coulin's sign, which is around the umbilicus. So this is a lesser sac. The inflammatory contents and exudates go into the lesser sac, forming a pseudocyst which is lined by an inflammatory epithelium. This presents as an upper abdominal swelling, especially when the patient is in near-elbow position. The general signs are fever and tachycardia. It can present as hypovolemic shock in severe cases due to the loss of excess fluids. Patient is found in leaning forward position, and tinge of jaundice can be present due to obstruction due to gallstones. So summarizing it again, abdominal pain on leaning forward position is present with mild tenderness and rigidity. And this is here the Coulin's signs, which is around the umbilicus downwards here. This is a grey Turner sign, bruising around the loin region. So in acute pancreatitis, the inflammatory cytokines are released, creating inflammatory cascade reactions. This will result into systemic inflammatory response syndrome known as SIRS, which will result into multiple organ failure. SIRS can present as shock. It can be due to loss of plasma in the intraperitoneal and the extraperitoneal space. Due to loss of blood, you can see the loss of blood in case of hemorrhagic pancreatitis. This is the ground glass appearance of the lung, which is ARDS, that is acute respiratory disorder, which can cause respiratory failure. Prolonged hypovolemia can present as renal failure. And consumption coagulopathy, that is DIC, disseminated intravascular coagulation, and the stress ulcers and paralytic ileus are common presentations in SIRS. So these are the systemic complications, all of these. Talking about local complications, pancreatic pseudocyst and pancreatic abscess are local complications. Pancreatic pseudocyst is lined by inflammatory epithelium. Inflammatory tissue. So differential diagnosis. It should be differentiated from all other causes of acute upper abdominal pain. The perforated peptic ulcer, which will present as broad like rigidity and tenderness, acute cholecystitis and biliary colic, pain on the right hypochondrial region, acute mesenteric vascular occlusion, leaking aortic aneurysm, acute myocardial infarction, which can radiate to the epigastrium. So in acute pancreatitis, there is marked systemic but minimal local symptoms. In perforated peptic ulcer, there is marked local symptoms. And in acute myocardial infarction can be excluded by ECG. Thus, all of these items should be excluded. If neglected, any of them can be fatal. Investigations. The diagnosis is established by exclusion of other causes. Let's talk about labs. Serum amylase, urinary amylase, and the serum lipase. Here we will explain these labs in the curve. In this, the normal level of serum amylase is 100 to 300 international unit per deciliter, and the serum amylase is non-specific, while the serum lipase is specific. Non-specific in the meaning that the increased level of serum amylase does not necessarily resemble acute pancreatitis. It may resemble perforated peptic ulcer. It may resemble other differential diagnosis. But other causes of increase in serum amylase doesn't exceed the level that is 1000 in acute 1000 international unit per deciliter. In acute pancreatitis, the level is more than 1000 most of the times. While serum lipase is specific, and serum lipase has longer half-life. So this is serum amylase, which is increased more than 1000 international unit per deciliter, and it remains increased for 2 to 3 days. And the serum lipase, which is increased and it remains increased for a longer period of time. It has longer half-life, so it is important for delayed presentations. Urinary amylase. When the serum amylase is excreted through the kidney, it starts appearing on the urine at the start of the day 2 from the presentation of upper abdominal pain, and it starts rising from the day 2. Labs. ABG to assess the need of mechanical ventilation. Mild bilirubin elevation. Hypocalcemia, of course, because calcium combines with fatty acids. Hypoproteinemia, because the protein are destroyed. Increased blood urea. Hyperglycemia, because the pancreas is affected. CBC, there is leukocytosis. Imaging. Let's start with plain X-ray, which is very easy imaging. Here we can see a dilated portion of the small intestine, which is known as sentinel loop, and we can see a distended transverse colon and collapse of descending colon, not ascending colon, okay, that is a mistake here. It is known as colon cutoff sign. So here's a X-ray picture. This is distended transverse colon, and this is the collapsed descending colon. Okay, this is colon cutoff sign. Moving on to abdominal ultrasound, it will show stones in the bile duct. In the lower part of the bile duct, abdominal ultrasound doesn't show the stones. Rather, it will indicate the presence of stones by dilation of biliary tree. CT scan with IV contrast. There is no pancreas without CT. Anything in pancreas, CT is the must and best investigation. So keep this in mind. Any disease in pancreas, CT is the best investigation. Any disease in biliary tree, ultrasound is the best investigation. So it is very useful in diagnosis. So this is a normal CT, abdomen. Here we have aorta, inferior vena cava. This is a liver. On the right hand side, on the left hand side we have a spleen and aorta. This is pancreas over here. We can see here this is a splenic vein and the splenic portal confluence where it joins with superior mesenteric vein, and this is an stomach. In acute pancreatitis, this is, you can see here, three important features. One is enlargement of pancreas, peripancreatic edema, and intraperitoneal fluid. Here you can see localized edema around the pancreas and excessive fluid collections around the pancreas. This is a CT scan with IV contrast. Here we can see the enhanced portion, island of enhanced portions, very little enhanced portions, resembling or denoting necrosis of the rest of the pancreas. It is one of the most important investigations. CT scan should be performed at least 48 hours after the onset of symptoms to detect extent and severity of necrosis. This is performed after a week because the early can underestimate the necrosis. So another investigation is MRCP, that is magnetic resonance cholangiopancreatography, where you can see the magnetic resonance images, especially in cases of choledocholithiasis suspicion, ECG and cardiac enzymes to exclude myocardial infarction. Assessment of severity in case of acute pancreatitis. It is done in order to identify severe cases that require ICU. Ranson's scoring system. We perform something on admission and we do some investigations on the initial 48 hours. On admission, we can make a mnemonic XA law, and in initial 48 hours, the mnemonic is CHOPS, CHOPS, CHOPS. It is a name of some person. And XA law, G stands for glucose. If glucose level is, A stands for age, L stands for LDS, AST, and W for white cell count. Glucose level more than 200 milligram per deciliter scores 1 point. Age more than 55 years. LDS more than 350 IU per liter. AST more than 250 IU per liter. White cell count more than 16,000 per unit liter. And C for calcium, serum calcium less than 8 mg per deciliter, indicating hypocalcemia. Hematocrit decrease more than 10%, which denote hemorrhagic pancreatitis. O2, that is arterial PO2 less than 60 mmHg, which denote lung affection. Burn elevation, which denote more than 5, which denote renal function affection. And base deficit more than 4 milli equivalent per liter. And S stands for sequestration of fluid more than 6 liter. So if the score is more than equal to 3 criteria, if the criteria fulfills equal to 3, is equal to 3 or more than 3, it is severe case that require ICU admission. So moving on to treatment, first we need to differentiate between the mild case of acute pancreatitis and the severe case of acute pancreatitis, because severe case is treated in ICU with proper care. So essentially the treatment is conservative in most of the cases. The aim is to support different body systems. There is multiple organ failure, so you're going to support different body systems. And this treatment regime is remembered as R regime. So the R regime of treatment stands for, the first thing we're going to do is we're going to relieve the pain by pethidine. We can combine with it atropine in order to counteract the spasm of sphincter of Oddi induced by opiates. The second is the replacement of lost fluids by crystalloids and plasma. Blood can be used in hemorrhagic cases. And after that, what we can do is monitoring by vital signs, urine output, central venous pressure. And if needed, if there is hypocalcemia, we can add calcium as required. And the R is respiratory support by oxygen mask or by mechanical ventilation according to the need. The fourth one is rest of pancreas and bowel, that is no oral intake, nothing per oral. Intravenous fluids are given for a few days until vomiting and nausea stop. Nasogastric tube suction is sometimes needed, and severe prolonged cases require total parenteral nutrition. And there are is a resistance of infection by prophylactic antibiotics, especially imipenem, cilastatin. And there are is a removal of obstructing stone by ERCP and reassessment when the symptoms completely resolve by ERCP. So this is ERCP. This is the common bile duct and the stone here. This is the duodenum. We insert the ERCP to the mouth, to the duodenum, and we shoot a catheter inside. First we do sphincterectomy, and after that we shoot, and there is something called Dormila basket which will crush the stones. The stone is crushed by Dormila basket. So this is ERCP, but the ERCP is only indicated when there is obstructive jaundice or cholangitis. Neither is not indicated. ERCP is contraindicated unless it is the treatment, unless it is therapeutic. We can't do ERCP in this case for diagnostic purpose, because ERCP itself can induce acute pancreatitis. Surgical treatment. Surgery is indicated when there is doubtful diagnosis, mostly confused with mesenteric vascular occlusion. And it is also indicated when there is severe necrotizing pancreatitis. Necrotic tissue are removed and drains are left in intraperitoneal cavity. Drainage of pancreatic abscess or pseudocyst. Pancreatic abscess, the drainage is performed externally through a tube, and for pseudocyst there is an internal drainage inside the stomach. So this is all about acute pancreatitis. Thank you for watching this video. I hope you enjoyed this video. See you in next video.